Odds of it still being there 12 years later, 93%. And that was with forceps removal. So I'd argue that the Benex only stands to last longer.
Okay, so you have your patient, they've come in, they've fractured their upper premolar at gingival level, kaput. There is no ferrule. Like, you can maybe get your perio probe inside and feel maybe a millimeter subgingival, but there's hardly any tooth structure left. What are you gonna do? Right? Because most of the times it's going to be for the bin, right? Like, it's hopeless, let's extract it. Now, if you want to get really extravagant, you could arrange for orthodontic extrusion, which takes time and is costly, or you can do surgical crown lengthening. Also incur a fee, but also involve surgery, obviously, and it will also mean that the patient will have potentially black triangles, and the gingival zenith of that tooth will now no longer be the same as the adjacent tooth. So again, that all takes time and money and effort. So a lot of times people say, let's just take it out and stick an implant in, a bridge in, whatever. Now, what if I told you there was one more way? This way I was exposed to it on social media, actually, in about 2017. And in 2018, I attended a BARD lecture about the Surgical Extrusion Technique, and it was interesting. It was an Italian chap, Dr. Bacciani, talking about this technique, and it was the first time I'd seen it presented in a scientific way. And then, if you remember, in 2019, I did a lecture or a podcast with Dr. Oz Olani, restorative consultant. It was restorability with a restorative consultant, and I discussed a technique whereby you can partially extrude surgically a tooth and then gain ferrule and restore it. And I said in the podcast, hey, I don't know if anyone's doing this technique in the UK. Please get in touch if you are. And fast forward a year, someone's doing it in the UK, and they've done a lot of cases, and he got in touch. So Dr. Peter Raftery is joining us for this episode. Protrusive, welcome to this episode on the surgical extraction technique, aka the partial exodontia technique. And this is going to blow your mind. If you've never been exposed to this, you're going to think, whoa, how is this even possible? It's basically taking that aforementioned broken down tooth and extruding it surgically, so be it with a luxator or with something called a Benex device, and now you let nature heal it, maybe with a splint, okay, like one of those wire splints, not the kind of splints I bang on about all the time, and then a few weeks later, you go back in to do your root canal, and by now, the tooth has fully healed, which is amazing. Like, biology is amazing, right? And now you have a ferrule, and you can now restore this tooth, which was otherwise unrestorable. So today with Dr. Peter Raftery, who's an endodontist based in Portsmouth, we're going to be talking about this technique. He'll walk us through all the stages of this technique, case selection, things that can go wrong, what advice he would give to a person doing it for the first time. And we also take a look a little bit at the evidence base as well for this, because I think this has a place in general dentistry, and now we know that implants are not the panacea we once thought they were. Therefore, I think this technique could be pretty worthwhile, even if for the odd case here and there, maybe for an upper second premolar as your first case, that you want to just surgically extrude it and give this tooth a second breath of life. So I'm going to dive into the interview. Now, before I do, obviously, I owe you a protrusive dental pearl. What do you guys dip your retraction cord in? Or what do you use to get hemostasis? I've used a lot of things in the past, like ferric sulfate, Expasil, that kind of stuff. But you know what? My favorite still, and this isn't sponsored or anything, this is just me sharing for those who don't know about Viscostat Clear, is 25% aluminium chloride. And what I love about it is the hemostasis that it achieves without that horrible brown nasty residue, which you can sometimes get with ferric sulfate. And also, did you know that ferric sulfate can interfere with bonding? So anytime I'm doing like anterior crowns and I'm using retraction with cords, I'm always going to be using Viscostat Clear. In fact, anterior posterior, I'm just using Viscostat Clear everywhere. I ordered this big tub of it, and my nurse knows that it's the only astringent, I guess, I will use. So big shout out to Viscostat Clear, which has just been brilliant, and I've really enjoyed using it. No more horrible brown mess. So I hope you enjoyed that material selection pearl of Viscostat Clear. Let's dive into the episode so we can learn more about this surgical extrusion technique, aka partial exodontia technique. Dr. Peter Raftery, welcome to the Protrusive Dental Podcast. How are you?
Very well, thanks. Excited to be on. Thanks for making it happen.
No, thank you, because what we're talking about today is something really cool, and at the moment, I would say it's very much niche. It's very much eyebrow raising. Some people, maybe an implant dentist, might say, "What's the point?" And basically what it is. And there's so many different names for it. But before we get into the beautiful part of the sort of discussion where we talk about the technique and what it's all about, is just tell us, set the scene for us a little bit, Peter. Where are you based? What do you do? What's a normal week for you?
Yeah, so endodontist, Eastman trained endodontist, maybe 10 years now. You sort of forget after about 3 or 4, don't you? But I am down in Hampshire, where the majority of my week is my endo practice in Havant, and I'm a day a week in central Portsmouth, one town over, at like a micro dental school. I think it's called Portsmouth Dental Academy, and it's primarily involved with training nurses, hygienists and therapists. But my involvement is with King's College London. So that's the biggest dental school, I believe, maybe in Europe. And I assume that the massive final year, 160 of them, they can't all get a dental chair maybe at the same time. So Portsmouth is called their outreach, one of 2 places that final year King's College London undergrads come down, and I'll supervise those final years, primarily in endo with a bit of everything. So that's my 1 day a week. And that's how I got to hear about your podcast, actually. So it's, whilst endo can be a little bit blinkered, not quite single-handed practice. I've got an associate, but you are at the coalface and you're a little bit head down. Whereas I love my Thursdays in that I have colleagues and we can, chew the fat and stuff like that. And over lockdown, everyone turned to podcasts, didn't they? Everyone turned to searching them out and listening to them. Clearly, you've been producing them. And a colleague, David Brown, said to me, "Peter, the thing you've been banging on about was mentioned in a podcast I was listening to last night." So I then look it up, and I don't know, a few days later, I was Instagramming you. And, 4 months later, maybe we found a date that could fit. So, yeah.
You're a very busy guy. You're very difficult to get hold of, Peter. How many kids have you got?
Yeah. They'll be wandering in any minute now, like BBC style. But yeah. Down here in Hampshire, married to GP, 4 kids, yeah.
4 kids, amazing, fantastic. Well, I'll set the scene for those listening at the moment. You got in touch with me because you had been told about that episode, and it was something we sort of mentioned in passing towards the end of the episode. And the episode was restorability with the restorative consultant. Was it Oz Olani? Yeah. And I'd mentioned this to him, and I forget whether he was very familiar with this technique or not, to be honest with you, but I mentioned it to him because in 2018 January, I went to a lecture at the BARD, the British Academy of Aesthetic Dentistry, and there was a chap, I'll read his name, it was Dr. Riccardo Becciani, and I probably said that horribly wrong, but that was one of the first times I'd seen a scientific presentation on the technique. So pretty much 2 years ago now, I saw a scientific presentation, but the first time I ever saw it was on Facebook, and I was gobsmacked, right? But then after seeing the scientific literature, and then now seeing your cases on social media, it makes so much sense. But before we dive into the nitty-gritty, can you just tell us what the different names for this technique are, and what essentially is it?
Yeah, so I know it as Benex, and we'll call it Benex. Benex is, portmanteau, I think, of the guy's name, the Belgian, I believe, that maybe, let's say, invented it, and extrusion or extraction, because it's a method or a device for extruding or extracting teeth. Yeah. And I have my endo practice, and we're just an endo practice, so I don't have all the other specialties nearby. And the reason I mention that is if I did, I would maybe say, it doesn't look savable, but you know what? Next door is the prosthodontist guy or the oral surgeon guy or whatever. But so I do feel this real, I do feel a duty, maybe even more than most, to try and avoid saying I can't help to the patient or the dentist, okay? And one of the style of case would be the old school post and core crown that has no ferrule, and the white bit has fallen out, and so it's flush at gum level, right? The dentine is flush at gum level. And so restorability and avoiding saying I can't help were a big deal. And I heard it was at a British Endo Society meeting that the distributors of the Benex device had a stall, and kind of sowed the seed. And I attended a course maybe a year and a half ago now with a professor from oral surgery from Birmingham Dental School, Thomas Dietrich, German guy, and it was great. And there were endodontists on it, and there were implant dentists on it. The endodontists are interested, I guess, in extruding. Let's stick with those decoronated teeth, extruding the tooth to, hey presto, get ferrule. So now it's not unrestorable. And the implant dentists on the course were most interested in the most atraumatic of extractions to minimize, I suppose, the need for bone grafting or delayed, placement while they wait for the bone. I don't know what I'm talking about now when it comes, but I suppose delayed placement of implant because they've lost the bone or something, or that kind of thing. Atraumatic extraction for those guys, and for me it's extruding teeth.
Well, sometimes to understand a new technique, we have to look at potentially a new technique is different, it depends on what the origin of it was. And we'll get into that. But sometimes to appreciate a new or a different way of doing things, we have to look at the alternatives. So the alternatives of a tooth, let's say an upper first premolar, okay, common tooth that have fractured at gingival level. Maybe you got 0.5 millimeter of ferrule palatally and mesally, and then the rest is maybe equigingival. And you can maybe in the sulcus feel an extra millimeter, but for a lot of people, that's unrestorable, so extraction and maybe for an implant. For some people, if you wanted to, you can do surgical crown lengthening, right? You can cut some gum away, cut some bone away, and hey presto, you now have some ferrule. And I guess the other way, those are the real two ways I can think of to make, orthodontic extrusion. So using orthodontics to extrude a tooth. But what you're talking about is surgically extruding tooth. Now, you mentioned the Benex device, but interestingly, the lecture I went to in 2018, the guy was just using a luxator, right? Which has its risks. Right. We can talk about it has its risks. So imagine just luxating a tooth until it's just loose and you can almost just pull it out. But instead you then suture it and you tack it to the adjacent teeth and you let biology do the work. The root canal happens. And for you, I want to find out from you exactly when to do the root canal. It'd be nice to hear the sort of sequence of things. But then it's a very innovative way, I think, to make an otherwise unrestorable tooth or needing a very extensive other slow work to make it restorable. So that's amazing. So tell us, how many cases have you done, and tell us a little bit about how you found it.
So the course I went on was maybe a year ago, and I'd say so. Funnily enough, he's running one soonish. By the time this podcast goes out, we'll have the info for those who are interested. It's probably good timing. But about a year ago, I went on the course, bought the thing there and then, and I maybe have done, I'd say 18, 20, something like that, I'd say. What I love about it is there's nothing electric, nothing battery, no battery, no batteries, no iPads, nothing rechargeable, nothing to Bluetooth to anything else. And I love that it does rely on some really old school stuff that everyone is familiar with. So I'm talking, probably everyone has in their window, I do, of their practice, what to do if a tooth gets knocked out, right? Kid's tooth knocked out, everyone knows, put it back in again. So avulsed teeth, we all know, can have a second lease of life if managed correctly. And everyone also knows that chief among those priorities is get it back in quickly. So teeth that are extra alveolar for a short amount of time have a pretty rosy outlook, future. Another thing that really relies on is, I suppose, doing a parapost. It's a lot like doing a parapost. So we've got this, the upper premolar roughly drilled down to gum level. You can certainly see the root canals, let's say. The pulp chamber is exposed in the example, the roughly decoronated example we mentioned. So I will then take an x-ray. I want to know that the roots are not very curvy, not like a banana, because I'm trying to scooch this thing out. So it is broadly limited to straightish rooted teeth.
What about not just the curves? What about if they got a bulbosity at the end? That is also going to complicate matters.
Yeah, I had a nice one just the other day. It was about the most curved one I've tackled, and it came out without a bother. Again, I'll try and provide, I'll try and show you what I mean. So 1820 cases. I haven't got a vast experience. I haven't had the big bulbosity. I might well resort to the more widely understood, accepted, known surgical crown lengthening, but you get the extra long white crown that no one loves. Mm-hmm. And the periodontist fee, and the periodontist fee is big, along with my endo fee, along with some crown placing fee.
You might as well have an implant.
So I don't know if I don't know whether I think that once I, as a specialist endodontist, have to involve a specialist periodontist, and there's a crown in the offing as well, whether it's realistic economically, or whether the patient's going to go, do you know what? I've done a back of the fag packet sum, and an implant would suit me better. Or ortho extrusion, we're talking months. The one time I formally sought that as a realistic, from a specialist endodontist down here, it was 3-4 months. I'm pretty sure, it was so long ago, but I'm pretty sure it involved actual train tracks, not just like 3 teeth. I think it involved train tracks, and certainly the bill was even bigger. So I found it to be the most realistic and instant. So I've got this tooth again. I can see the canals, so I will then put, let's get a Gates Glidden or an SX.
Can I stop you, Peter, if you don't mind? Because I'm liking the journey. I want to put it into chronological order. So you've identified your patient, you've checked the PA, you've noticed that, okay, it's not curved, which is great. You're now going to use the Benex device, and maybe towards the end you can share a case showing how to use it. And for those listening on the podcast, I'm not going to bore you guys by having too many visuals for you to listen to. It wouldn't make sense. But go back and check the video and check Peter out on Instagram and whatnot, his social media, to see the images, whatnot. But I think it was still interesting for you to listen to the workflow, be exposed to this. So you've got your PA, you've used your Benex, you've got it extruded. Now, let's have a little debate here, because some of the images you sent me, you took the tooth entirely out. But I would say to you, is that really necessary? Can't you just extrude it a little bit and keep it in, and therefore you don't get any air time of the cells?
Sure. So desiccation or what have you of the PDL is the biggest deal of all. But the argument, and it's a neat one, and it's not mine, is I'm just parroting what I heard on the course, but it was that you want to know if you've perforated this tooth as you've sunk down the canal, this like a parapost drill. It's a lot like a parapost drill. So you want to know if you've perforated it. I guess you might want to know if it's cracked. You perhaps want to know if the root has come out intact, or whether that banana hook on it has snapped off. And those are the things. It kind of inspection of it, really. That makes
sense, because I sort of forgot the long sort of parapost-like structure of the Benex, and that makes sense now. And also, premolars are teeth that are very susceptible to cracking, and to be able to see that visually, I didn't appreciate that before, and now I can see that. So you've inspected it. You're going to put it back in. Now tell us what happens now. So
you've the device is a winch-like thing that because you've sunk this parapost style drill down the middle, and you pick up the matched in dimensions, let's call it a screw, because it then does tap down the hole you've drilled. It does tap because they're very sharp threads. It taps in, and you get this wonderfully firm grip, and then you attach that. We've done a parapost-like hole, and we've screwed the screw down it, and the screw's got a very bulbous head on it. And you attach that bulbous head to something that looks a little bit like, a fishing reel. But you then turn this device, and it very, very slowly winches on, or winches at, or yanks at that tooth. And eventually, I'd say 4 or 5 minutes, it just gives. Suddenly the tension's off you start to see a little bit of bleeding in the sulcus. You put away your apparatus, Benex, and you then pull out on that screw. You've got the tooth on the stick, and you inspect it, and you get a photo for Instagram. You then put it back in again. You put it back in again, less far, so that you're happy with the amount of supragingival tooth structure you've now got.
And how much are you aiming for, Peter? How much ferrule are you aiming for? Super gingival.
Yeah,
because you can be a little bit greedy. You could just be, hey, I want a little bit more. I mean, how much is good?
This is it. I've some of the cases I've only noticed in hindsight, if that makes sense. But there's no post involved. You'd think so. Having done the Benex to gain an adequate ferrule, I've then found I didn't need a post, whereas I would have thought I'd be maybe relying on a bit of extra ferrule and a post and a really switched on restorative dentist. But, it hasn't required the complication of a post, which has been great so far. So, yeah, from the X-ray, you're identifying your non-curvy roots, bulbous roots. And usually on these anterior single straight rooted teeth, you've got a wealth of root buried in bone. So you can be greedy-ish, I guess case dependent, but you put it in less far. The average seems to be an extrusion of, I would have thought, 3, give or take, 2, 3, 4 millimeters. And then you put it back in. Then I suppose you unscrew your screw. Mm-hmm. So at this point, you've taken it out, had a look. Clearly, you don't want to touch the ligament, which is why I'm emphasizing that you're holding the stick and you're not holding the root, because these cells, these nicely cleaved PDL cells, are all important. Put it back in again. And maybe now's the time to mention, I suppose, you haven't gone at it with forceps, so you're not risking damaging the cementum. Because, there's that. No one understands external cervical resorption very well, me included, but cemental damage is proposed as one of the things. So with your forceps and your grabbing, you haven't damaged the cementum. I know that when teeth are decoronated and I go after them with some forceps, I'm often tearing the gingiva a little bit, meaning to or not. But if there's no tooth structure there, supragingivally, that's why we're doing this in the first place. I think I'm often tearing a little bit of gum. So with the Benex, you're avoiding the soft tissue damage, the hard tissue damage. And maybe the final point, if I was cheerleading for it, would be, can you imagine like the cross-sectional shape of that upper premolar? It's not circular. So if I've got my forceps on it and I'm rotating it, because it's not purely circular, it's almost like an anti-rotation feature that you sometimes see in a post. When you go to grab that post as an endodontist, you're turning it. You're like, oh my gosh, I've snapped. You've maybe cracked the root. But then, so when you go to grab on the course, one of the most impressive videos was a guy trying to atraumatically, but with forceps, extract an upper anterior tooth. But you could see in slow-mo as he rotated it with great skill. But as he rotated it, you could just see the buccal plate break because it's vanishingly thin. This, as you rotate it, it's not circular, so it got a bit fatter on, I don't know what the physics or the maths term phrase is. The circumference got bigger suddenly, and it just broke that buccal. So the Benex way, you're avoiding that. Hard tissue damage, soft tissue damage. Yeah, you take it all the way out, put it back in again. Less than 15 minutes is the absolute key number. The longest I've ever got near was about 8 minutes, because that's how long it takes my tricalcium, my MTA or biodentine to set. I'll come back to that maybe later. But more often than not, if it's a simple case, just one where there's no tooth structure, the MTA or biodentine I mentioned was like when I'm repairing, say, a perforation or an external cervical resorption defect, or that, I've got to get at a defect which is underground, so to speak, like external cervical resorption or something like that. But if it's just there's not enough tooth structure left, and that would be the case to start with, no caries, just a decoronated tooth, that's the one to start with. They're coming out for just as long as it takes to take a photo and inspect it, and it's going back in. So we're talking 2 minutes.
Which makes sense. You want to minimize extraoral time as much as possible, that's the most efficient way.
And when you see risk or decreased prognosis stratified, you're always going to see the 0 to sort of 5 minutes. So I would argue you got like, if you're 4 minutes with it out, you're as good as 0 minutes. You're in the best, so less time the better. But you do want to inspect it, put it back in. The shorter the amount of time, the less coagulum you might be dealing with. I have found maybe on one of those 8-minute waiting for biodentine to set, it's a little bit harder than I would have liked putting it back in. I don't know why, but I wonder if it was a bit of a jelly-like clot. I wonder. But it goes back in easy. You then de-thread the screw from your tooth, and then you're splinting it. Again, I'd go back then to trauma guidelines. That's probably a semi-rigid, i.e. flexible, 2 weeks.
One tooth either side, or a couple of teeth per side?
It would be, one. I'd say one either side.
So if you go the upper premolar, you're putting on the canine, and the second premolar, and you're tacking some composite on any sort of enamel, dentine, even cementum, maybe, whatever you can get hold of. And you're probably being quite generous with, I imagine, with the composite on the extruded tooth, because you want as much locking as possible.
I wish I was better at bonding. So everyone will be better at me than the splinting of it. So I've found a top tip for beginners would be to, the locals kicking in, I would be etching and bonding when the environment's bone dry and everyone's calm. I would be etching and bonding my 2 teeth next door, and perhaps even applying a layer of composite there and then, so that when the tooth is out and it's a little bit mild, chaos isn't the word, but mildly stressful, and there's bleeding, crucially, inevitably, then you want to leave as little bonding to do at that point. So I've learned that the hard way. I learned that myself.
That's a top tip right there.
Do a lot of the bonding early on. Yeah,
has it ever happened where you've started to reintroduce the tooth back in, and then blood has just squirted out the socket onto the adjacent teeth, and you'd have to start the bonding again? Yeah, absolutely. I've had some
20-minute overruns trying to etch something for the 15th time. No one's as bad as etching than me, but bonding and adhesive dentistry. All my buddies, they were, the one thing I'm going to be texting them is, tell me again how you get good.
I appreciate that insight. This is very, very honest and good of you. And this is the nitty-gritty details that we love on this podcast. But I just want to ask you, any sutures? Because the Italian chap, Dr. Becciani, he wasn't using a Benex, and I'm sure he'd love the idea of using a Benex, because even in his lecture, he said that, he uses a luxator, and he's very gentle, takes his time, but you have to warn the patient that, hey, if by using the luxator a good chunk of the tooth breaks away, which it can do, then it's capiche. We're going to commit to the extraction. Right. Whereas with the Benex, yes, I'm sure there's risks and issues and perforations and little things like that can happen with the Benex, but it just seems like a much smarter idea. But then what he would do is suture either side. And I actually forget whether he used a semi-rigid splint. He may have just relied on suturing the papilla either side and that keeping it still. Do you think that's enough?
A bit like a almost looks like a spider web, or sort of holding it in place, and that's what you see. That's what I see when you're looking at these auto transplantation cases where they're pulling out a partly formed 8. To put it into a socket of a knocked out front tooth, or something, maybe a bad example. But you've seen them stabilized with sutures. But no, and funnily enough, one of the papers in the Journal of Endodontics recently, CHO was the CHO, intentional replantation. She was doing it with forceps, and the interesting point was, in the majority of cases, there was no splinting whatsoever. It was a snug fit. You'd be surprised. Yeah, just a snug fit. I haven't tried that. I'm pretty dogmatic. I've stuck to this fishing wire and composite, and I've found that when I left it 6 weeks, the teeth would come back rock solid, but with no evidence that I'd ever put my splint in the first place. It had been chipped and broken away, much to my embarrassment. But the teeth were, without fail, rock solid. Not bad rock solid, not ankylosed rock solid, but just incredibly, beautifully, as they should be, with all that ferrule and everything's nice and pink and healed. But I'm nibbling away at that because, in the sort of private dentistry world, patients want, done already. And the trauma guidelines are 4 avulsed teeth, 2 weeks semi-rigid, and my splints aren't lasting. So I've moved towards 2 weeks. And I would say that I'm finding my splints are there more often, but the teeth are a little bit wobbly. So again, my beginner's top tip would be to start their first couple of cases would want to be probably about a 4-week review. Remove the splint, I would say 4 weeks later, because I'm convinced they will find the teeth to be unequivocally rock solid, and it will absolutely be very quick proof of concept.
I think the first time you probably see that after doing this, the first time you see it come back rock solid, you're probably like, whoa, it actually works, right? So that's crazy. And the second thing I just
funny,
had
they say, there's nothing new under the sun. We're effectively talking about replanting a false teeth, but I feel like I'm almost, privy to a secret that no one else knows about. I'm banging on about it, but I just feel, ultimately we're talking about a false teeth and putting them back in again, and then being amazed that they last, even though we've been telling school mums to do it for forever. But it really does work, and it's so atraumatic that we shouldn't be surprised, but.
It's a very, very valid point. One idea I just had, just speaking to you, the restorative dentist in me is just thinking, right? Because you said private practice, patients don't want to have a gap. So if someone's broken their fall and they're like, quick, do something, and you're like, well, I kind of have to splodge it out a little bit, and then you have to be like semi-toothless for 4 weeks or whatever.
Yeah.
When you're doing your splint, how about doing your splint and then just building the tooth up in a massive blob of composite at the same time, just shy of any sort of occlusion, but then also telling the patient, do not chew on this tooth at all. Have you tried that? Is that something that's worth trying?
Yeah, well, no, I've shaving down the period to 2 weeks is okay. The patients are generally delighted and a little bit more forgiving. I'm sure that'll wear off as it becomes, more old hat. But I have found that they'll generally go from decoronated gap, actual gap, and suddenly you're filling 2/3 of that gap with tooth-coloured tooth structure. And you're right, the whitish composite that I went into endo because of a lack of interest or ability with cosmetics. So I imagine your hunch is accurate, but I couldn't say either way.
It's just something I probably will try when the right case comes along. Let's talk longevity. What does the evidence say? Share with us, what is the existing evidence base for this, and what can we learn from the evidence base?
Yeah, so I'll go with this Cho paper because it's high in, it's in a proper journal, it's recent and peer reviewed, and there so with forceps extraction, they found their hunch or their statistical thing was for 12 year odds of 12-year retention at 93%. Spectacular, right? Odds of it still being there 12 years later, 93%, and that was with forceps removal. So I'd argue that the Benex only stands to last longer. When it comes to the things we're worried about is ankylosis, I guess. So I would say the way we're handling this tooth gently, and we're putting it back in quickly. Those figures didn't surprise me. Now, things like endo unraveling it, or I get the feeling that's kind of within our remit. That's like if that happens, it's kind of my fault. If I introduce too aggressive a crown root ratio and so there'll be some. I'm sure there'll be some mechanical failures, perhaps an overambitious project, as it were, candidate tooth, but and there might be presumably a little bit of ankylosis, external replacement resorption. But I would argue, to answer your question, in very, very good longevity is what I'm expecting. I've found all of them to be rock solid, as I've seen, and I've had some, been doing it, just over a year, and I've had a good few. I review my endo at 6 months, so I've reviewed, I'd say about 3 of these cases so far. And they don't sound tinny, ankylosed. They're not unmobile, or they're the right mobility. And I could see a nice outline of a root on my periapical. So ankylosis is the only thing I'm worried about to date. the endo that I'm doing, I feel like a responsibility, or I'm able to eradicate the risk of external inflammatory resorption or things like that. So yeah, the things that worry me, I suppose, are ankylosis, and I have, but I'm really encouraged by the evidence from that paper in the JOE and Journal of Endodontics. But this technique has been published in the BDJ by Thomas Diedrich, the professor of oral surgery at Birmingham Dental School. It wasn't kind of a longevity thing, but yeah, it's not as, once you scratch the surface of PubMed, it's not as novel as you that we would both think it is.
Well, I'm glad you shared those with me in an email exchange, so I'll put them on the Protrusive Dental Community Facebook group and also on the website in the show notes. And prior to you sending me all that, I only knew of the 14-year case report presented by that gentleman who presented, and he said some great things. An interesting question I asked him in the audience, actually, and for asking the best question that day, I won a Reliax Fiber Post kit. But thank you, Nick Sethi and the Bard team. But the question I asked was, in the trauma guidelines at the time, I believe, an avulsion of any sort, I think they said antibiotics is a good idea. And I sort of said, hey, do you think antibiotics would help? And the guy was like, no, we don't think so. And would you agree with that?
I'd agree with the lack of a need for antibiotics, if I'm honest. Because you're right with trauma guidelines, but we're talking that's the tetanus and it's this dirty tooth, etc. Mm-hmm. But again, I'm encouraged for Benex to outlast traumatized avulsed teeth.
Of course,
because there's nothing atraumatic about an avulsion, right? There must be, I'm thinking a cricket ball in the mouth. There must be a massive amount of crushing on the palatal aspect of that root, and probably a bit of alveolar bone fracture as it's knocked out intact. Whereas this can be the Benex, the winching, and it just is like, I don't know, shucking, watermelon pit. It just comes out, it cleaves out ever so neatly. And you can really imagine that not a lot of structures were harmed during the making of this, Instagram case sort of thing. So you really are bypassing that cemental damage, the alveolar bone fracture, the muck maybe that's got into the sulcus, and all those things, yeah.
Quick question, actually, I just thought of. At the time where you successfully extrude the tooth, do you ever get a ruler and quickly put it and measure the working length?
So, because I've taken... No.
Is that a daft idea?
No. My Root ZX is a trustee for that job later, but the academic that I've been bombarding this professor with cases, trying notice me, but he has said, oh look, glad to hear someone else loves it like I do, and he's asking me to maybe keep some sort of formal of how much I'm so there might be a bit of measuring. He wants to know how much I'm extruding it and all, but so far I'm just kind of doing it by eye, and I'm getting everything super gingival. Which
is your bread and butter. You're an endodontist. This is something you do day in, day out. Amazing. Yeah. I think we've covered well what the technique is, some of the nuances of it. Before I get you to kindly share a case for those who will come on later on Dental and Tubules, Claim CPD, watch the case, that sort of stuff. If you can share... Me, myself included, there will come to a time, and the reason I haven't done it yet is because COVID happened, and we're all out of practice, and I've joined a new practice, and I'm waiting for that right case to come along. And you being an endodontist, you probably see you get much more exposure to this sort of stuff. I'm waiting for the right case to do it, and I'm more than happy to give it a go. It'd be nice to have a Benex, so I would feel much more confident with the Benex than current situation. I'm probably using the finest luxator with care, like Dr. Bacciani did, but ideally with the Benex. But what advice would you give someone like me? You already gave a few little nuggets about the pre-etching, pre-bonding. Any other advice to a first timer?
Let me think. So the Benex kit, it's expensive, but so it's won't surprise. It's just more than £1,000, all said and done.
I think that's great. Because an implantologist, because I think implantologists can use it. When you're doing endodontics for in this way, partial extrusion or surgical extrusion, I think the application is brilliant. But I'm sure even with the tricky extraction, you can just set this on and then let it help you as well.
Yeah, absolutely. So on the course, the implant dentists were learning about sectioning, let's say, an upper molar into the 3 roots and taking them out individually. But yeah, so if you want to get fanatical about this atraumatic extraction, then yeah, you're sectioning the root, but it's £1,000. So yeah, you'd be pre-bonding the 2 teeth either side. So I would have my lumps of composite either side. You don't want to be doing your first etching and bonding when there's blood around. An ideal tooth would be probably a 5, because there isn't the burden for the aesthetic. You can more easily persuade someone who's effectively not got a 5 to you don't have to go to the ends of the earth to give them 2 weeks worth of some sort of cobbled together aesthetic thing there. I would also suggest that, and I've stuck to what I learned on the course, was to I'm splitting my involvement into 2 visits, because if the tooth is cracked or perforated, or I've perforated it, or you wouldn't want to have spent so much time on it. So by that I mean, I'm on visit 1, I'm extruding the tooth and bonding it, splinting it, and 2 weeks later I am doing the root canal treatment. But clearly that second appointment goes by the wayside, doesn't happen if the tooth was 2 weeks earlier split, cracked, perforated, or whatever, or just proven to be unrestorable. So you wouldn't want to, let's say, quote or promise or charge or set aside the chair time for the whole thing in one go. You're sort of extruding it, and then 2 weeks later you might get reception to call the person 2 days before. Is the tooth still there? Yeah, our appointment in 2 days' time. You don't want that wasted chair time for them to bring in the tooth in a little Ziploc bag. So you're sort of splitting treatment into 2 weeks apart. Let me see. So I'd recommend some stiff putty. One of my clinical dental technician buddies put me onto some lab putty, which is very hard. I think Shaw hardness is the scale, and the bigger the number, the better. In the case that I sent you with the blow by blow steps and stages, you'll see that you sort of put a sectional impression tray full of silicone onto the tooth and one either side, and it acts like a little bit of a buffer or a bumper or a barrier as you start to apply this pressure, because as Newton's law, as the tooth's getting yanked up, there's a fair bit of pressure intruding, so to speak, those teeth either side. And I don't think you'd want to have something very soft. It'd be a bit bouncy and teary. You want something, a stiff silicone.
And that's specifically to do with the Benex technique, obviously.
Yeah, it would be. I would, beyond that, I'd.
I think those are some great gems there. So, Peter, can you show us a case so that those people who, once they're off the podcast and they want to go home and catch it, there's some visuals, they can check that out as well. Just share with us a case that you have.
Lateral incisor, post-crown decoronated, unrestored teeth either side. A little bit of a prominent lower incisor with a wear facet on it, which, so that's tough enough. And pre-operatively, we involved a prosthodontist in this about, would an implant work and all? Because I assume that this crown gave up the ghost after the proclination of that lower incisor bashing on it. But not a lot of ferrule, I hope we'd agree.
Yep.
The gingival margin wouldn't afford, in my view, to go very far north relative to the teeth either side. Not that you can see it in all, but you would maybe image 2. Can you see this there? I guess I've taken away the temporary filling, and again I'm just there are not a lot of tooth structure left. That's all. Next picture, the tooth out. So. A lot of root there, which is the whole point, right? A lot of root, nothing super gingival, but a big long root was sat in there. This is my sort of stick, as it were, and I'm pleased to say that's nicely parallel with the long axis of the tooth, and there was no metal glinting out the side. I was pleased to say, because before I put my Parapost style Benex drill down the canal, I'd flared it a little bit with, let's say, a Gates Glidden or an SX, an orifice flarer. That meant, I felt, that my Benex drill preferentially fell down the canal rather than created its own path with a little bit of apical pressure. It wanted to stay centered in the canal that I'd done a little bit of flaring of, more so than it wanted to wander off into a perforation.
Brilliant.
Next up, I hope, was 6 weeks later. And
brilliant.
Subtle, but it's just nice pink gum and I'd say a crucial bit of ferrule there. I won't dwell on it. I'll just bring up next image.
I mean, no, but that's great, because if you'd gone for a surgical crown landing there, as you said, you're changing. Yes, this might be a low lip line patient, but imagine it's a high lip line patient or a medium lip line patient. Then you're changing the gingival zenith on the central two incisors. You want as much symmetry as possible. So that is phenomenal. You've maintained the exact gingival symmetry to the adjacent tooth. That's amazing.
And I couldn't, as you can see, I couldn't have extruded it more in terms of it bashing off that lower front tooth. It couldn't really have come out more. Now, the restoring dentist has got a job on his hands, but we'd sort of agreed pre-op. And again, here's the X-ray, long route. If you can, in terms of trying to justify this, you could maybe see the size of that little black triangle pre-operatively was more or less, tiny. And I'm sure that this last image in this particular whatever will show it to, this is a post-op. And it's a nice big long triangle. Hopefully gives an idea, I guess, just of a decent amount of ferrule dentine there. Yeah, so an implant, my understanding of implants is that they're not a walk in the park when there's going to be, from that lower incisor, a lot of loading on it. It was enough loading to knock out that post crown after all. Resin bonded bridge, likely go the same way. So even though the restoring dentist has got a job on his hands, I think having, a pretty decent bulk of natural dentine will be the least bad option. That was our thing.
No, I really enjoyed that case, and would you be happy for me to share that with the listeners and watchers? Yeah. Do you mind sending me the image? Because I want, in my introduction, I want to say, hey, look at this radiograph. This tooth is unrestorable, right? But then look what the likes of Peter could do.
Of course,
people will find that very interesting, I think.
I'll barge you with some neatened up and ready presentable images. Yeah.
No, that was all fantastic, and
that was an ideal one. Because it was a bloke, you could probably tell, and he didn't mind the gap, and there was no caries, no resorption, a nice long root. There was no crown root ratio for me to worry about. That was and there were natural teeth either side, so my etching and bonding to enamel is ideal. That was the perfect.
It was a unicorn patient minus the class 2 div 2, but otherwise it was a pretty perfect patient.
Yeah.
Excellent.
I'm banging on about it a lot. I think it's great. Don't forget, we're just talking about putting a avulsing teeth for 2 minutes and putting them back in again. But I'm crazy enthused about it. I just find that I'm saying to less people, less patients, and less dentists, I can't help. Yeah, which is good.
I think it's amazing, and I'm so glad you've introduced this technique to people listening and watching, and you have definitely deepened my understanding of the technique, and I just love the Benex device as well for it. And I just think it's very admirable what you're doing to try and save these teeth. I mean, but we have to accept that some implant placing dentists will watch this and they will spit their coffee out because they were like, what the hell is this? You might as well have an implant. But it just depends on your mindset, where you come from. And I always say, and this is nothing against implant placing dentists, but sometimes when all you have is a hammer, everything looks like a screw. But I just think it's great that you're doing that. So thank you so much for coming on the podcast to share that technique with us.
Yeah, no problem. Yeah, it's funny. So something I should have mentioned right at the beginning was that, do you remember on the podcast, which was your 2019's most listened to podcast,
Well done.
I think you'd even said, I don't think this extraction and put it back in again that you'd seen was being done much in the UK. And you said, if anyone is, get in touch. And, lo and behold, here we are. How funny.
That is amazing. That is so good. And thank you to, was it David who
Brown,
told
he turned me onto it, and I'll he's a little community, the Portsmouth Dental Academy gang.
Thank you so much, David. Now the Protruserati, and thank you for recommending Peter to listen, and then eventually you got in touch. Now, I always say there's never been a better time to be a dentist, because now we're so connected, we can learn, we can share techniques. There's never been a better time. So with all the doom and gloom, I hope to bring some positivity, and thank you for joining me in that today. Thank you so much.
Yep, pleasure. Good luck. Nice to meet you virtually. I'll look you up at a conferences show and that sort of thing. I
can't wait. Brilliant. So there we have it, the surgical extrusion technique, or the partial extrusion technique. Isn't that fascinating, right? I mean, something that you would think is innately a bad idea. It just seems too good to be true, and it's just fascinating. I think the true secret, I guess, is case selection. Like with anything, like any technique, case selection is always the key. So choose your cases wisely. And I really do think having something like a Benex device, like if you've got access to a Benex device, wow, I mean, that's half the battle. That's more than half the battle, I think. Because if you're relying on luxators, then things can chip and break, and it may not be possible to do this technique. So those are Benex. Wow, you've definitely got one leg up, totally. But I really thank Dr. Raftery for coming and sharing his passion for saving hopeless teeth. So I hope you enjoyed that episode, and I'll catch you in the next installment of the Protrusive Dental Podcast. Thank you to all the Protruserati out there.